Welcome back. Hope you had a nice break. Happy to be starting off the afternoon with clinical practice guidelines as a foundation for implementation science. I have no disclosures, and I've listed my affiliations here. First, I want to talk about why CPGs might be a good fit for implementation research. And then I want to talk a little bit about how you might use CPGs to help with selection of the evidence-based practice as a focus for implementation science. And then a little bit more about the qualities of CPGs that allow them to be a strong foundation. And then finally, some pragmatic issues related to CPGs and recommendations. The implementation science to date has been done largely in areas of mental health, behavioral health, substance use disorders, public health, and medical and surgical realms. There are systematic reviews as evidence of an active and growing implementation research endeavor in rehabilitation. And I have informally collected a few here to try and just visualize what's going on in rehab right now. We can see quite a few, several systematic reviews, some in the areas of barriers and facilitators, as would be expected, some in the area of using standardized outcome measures, and then knowledge translation and CPG implementation and adherence. One thing I take away from this kind of brief review of systematic reviews is just, number one, there's a lot going on in rehabilitation and implementation science, and also there's a lot yet to be done and understood about how we implement things in rehab. In our last CoStar Institute, we saw a lot of research frameworks that were really helpful and helped us to visualize how to move forward in this area. I wanted to revisit them from the perspective of how to select a topic for an implementation initiative. And so here's one, the query implementation pipeline, where you see that the process starts on the left with identifying a research area, as most of these other frameworks do. Here in the designing for dissemination, the question in the upper right is there an evidence-based practice? Is there a practice gap? Similarly, in this Aaron's framework presented by Dr. Powell, the process starts on the left with a given evidence-based intervention. And then Dr. Sales starts on the top left with step one, assessing current practice gaps. Dr. Prue Becker went into a little bit with CPGs in her initiation, where she's looking at identifying strong recommendations, which are grade A and grade B from CPGs as a basis for identification of a performance measure. And that, I think, is the kind of a role that I would see for CPGs in implementation science. And I'll talk a little bit more about why. So where to start in selecting an evidence-based practice for an implementation initiative? My perspective comes from working with technology developers in rehabilitation and observing hundreds of new technologies. And one of the things that I saw was that passion often starts with a personal experience in a local practice setting, which is great. It's perfect. It just needs to be supported by additional evidence, evidence from the literature and evidence from stakeholders that validate the importance of that problem to other people. And so by doing that work of getting stakeholder input and looking into the evidence, one can avoid these important problems of having projects with lack of generalizability and inability to get traction with the necessary stakeholders, and also limited evidence to guide the practice. So it goes without saying, really, that one should focus on high impact problems, but how to find them? I'm going to offer a few buckets to think about in terms of choosing what those criteria ought to be. The project should be important to stakeholders, as many of the relevant stakeholder groups as possible. So policymakers, payers, health systems, clinicians, patients, and their support networks. There should be evidence of effective practice. This has been discussed by others, in all of our CoStar institutes. And there should be high impact quality improvement opportunities there. There should be a real need to make a change, as evidenced by a practice gap or variation in practice. And of course, it should be a feasible evidence-based practice. So let's think about CPGs as the foundation for implementing science. How does that work? Well, Dr. Proctor has already reviewed the critical seminal reports that guided the current state that we're in terms of developing implementation science for those solutions. I wanted to just focus on one of those reports, which is of particular relevance to clinical practice guidelines, and that is knowing what works in healthcare. In that roadmap for the nation report, the Institute of Medicine identified 3 requirements for a national health system to identify most effective healthcare, and those were priority setting, evidence review, and developing recommendations or guidelines. But it wasn't that simple. There were really big challenges from the start, really, with clinical practice guidelines. There was tremendous variation in clinical practice guideline quality, in the transparency in these guidelines and their recommendations that led to really a crisis of confidence in clinical practice guidelines. There was known incidents of stakeholders with vested interests in the outcomes of those recommendations being involved in the development of guidelines, and there were really high stakes occurrences of recommendations conflicting with each other directly in CPGs on the same topic. So this was really problematic. Another problem that had occurred, and still occurs really, is that recommendations may not always translate into measurable actions or activities. So I'm going to lean on Richard Rosenfeld here, who is a leader in guideline methodology in the otolaryngology community. And a couple of things that he said are worth simply quoting. From him, he says, one solution is to produce quality-driven, evidence-based guidelines using efficient and transparent methodology for actionable recommendations with multidisciplinary applicability. That's a mouthful, but it's aspirational and it's worth trying for. He also says, in terms of what those guidelines should be doing, guidelines help clinicians translate best evidence into best practice. A well-crafted guideline promotes quality by reducing healthcare variations, improving diagnostic accuracy, promoting effective therapy, and discouraging ineffective or potentially harmful interventions. In response to this crisis, Congress and the Department of Health and Human Services asked AHRQ to charge the Institute of Medicine to create standards to address these problems. In 2011, the Institute of Medicine published the IOM Systematic Review Standards and CPG standards. These standards have been used ever since that time in the US for clinical practice guideline development and are still very relevant today. This effort in the United States in the 2000s was influenced by and related to a larger evidence-based practice movement internationally that was going on. In 1998, for example, the Agree-To collaboration was developed to create a critical appraisal tool for clinical practice guidelines. And in 2003, the Guidelines International Network was founded, which is the current international community for methodology and science in clinical practice guidelines. So together, the efforts that were made in evidence-based practice in other areas, including, as noted here, the Cochrane Handbook, which is seminal for work in systematic reviews, as well as the Institute of Medicine systematic review and guideline standards, are foundations for rigorous clinical practice guidelines. CPGs can help to validate the problem by vetting evidence. Here's an overview of the Institute of Medicine standards for CPG development, the first being to establish transparency. The second is explicit management of conflict of interest. And the third is balancing the CPG development group with members from multiple disciplines and perspectives. The systematic reviews used in CPGs must meet IOM standards, and that means that all of the standards in the companion standard book for systematic reviews are subsumed into this one standard for CPGs. Also, explanation of the foundation for the strength of each recommendation must be done explicitly. There needs to be clear articulation of the recommendations and external review, including public comment, as well as plans for updating. So I'd like to just highlight that fourth standard, which we talked about, which is that clinical guideline developers should use systematic reviews that meet the standards set by the IOM. In addition, I wanted to just note that there are several models for conducting systematic reviews for clinical practice guidelines. Sometimes clinical practice guidelines will be developed around an existing systematic review that answers the relevant question. And in that case, the systematic review is separate from the CPG. In my experience in physical therapy, most times CPG developers conduct systematic reviews to address their specific questions, but there can be any model in between. For example, in some areas where there's lots of literature, the CPG developers may use existing systematic reviews. So let's talk about the principles that guide CPG topic selection, because those are going to reflect on how well the CPG validates the topic for implementation research. Broadly speaking, the main areas that people look to when selecting CPGs is the potential to impact large numbers of people, looking at making sure that the problem is associated with a high burden of illness. Often controversy is something that is of interest for a CPG to have the opportunity to weigh in and remove controversy. Public, provider, payer, essentially stakeholder interest is a critical aspect. And then really identifying an important quality improvement opportunity is a key factor in selecting CPGs. Keeping in mind feasibility is always important so that a CPG is providing recommendations that can actually be implemented in practice. And then the availability of implementation resources is also a consideration. I'm going to provide some examples of my experience from the physical therapy community in how CPG selection processes can help to validate the problem for implementation research. In the American Physical Therapy Association, in the process to select a CPG, the APTA consults with different departments who have different perspectives on potential problems. So, for example, professional, state and regulatory affairs, and the payment and practice management departments are consulted, all looking at high priority health conditions with known variation in practice and high burden of disease. In the Academy of Orthopedic Physical Therapy, CPGs are selected based on conditions that are most commonly treated by the membership. And in the geriatric and pediatric academies of physical therapy, I know that surveys were conducted of the membership to identify topics of importance to the membership. Another way that CPGs can help to vet problems is by including multiple stakeholder perspectives in the development process. The IOM standards require multidisciplinary and balanced guideline development groups and patient and public involvement. Although I won't go into great detail about this area, rigorous compliance with these standards will contribute to a highly vetted, highly relevant, and important CPG. The CPG development process conceptually goes like this, starting from the left with systematic search of the literature and systematic independent reviews of the articles that are extracted. The next important process is to appraise the included literature There are a couple of different ways to do that. In this example, we're using a level of evidence approach, which is a little different from the grade approach, which is also very commonly used. In this case, the studies are assigned a level of evidence, for example, based on the Oxford system, and then the articles are critically appraised by 2 independent reviewers using a specified critical appraisal tool. The level of evidence is then adjusted based on that critical appraisal. And from there, the body of the evidence is synthesized, and the benefits, harms, feasibility, and values are weighed in order to write the recommendation. Another way to use CPGs to inform potential implementation research initiatives is to think about the interest in the CPGs and the use of them. As an example, in the American Physical Therapy Association's clinical reference tool called PT Now, clinical practice guidelines received the most page views of all of the resources available. In 2018, 183,000 page views were recorded. If we look at orthopedics in the Journal of Orthopedics and Sports Physical Therapy, the number of page views for clinical practice guidelines has been increasing every year and will reach approximately 400,000 page views in 2020 for clinical practice guidelines. There is variation in the page views by individual guideline, so that can range from 2,000 to 65,000 views by guidelines, showing some really interesting variation in interest in use across the guidelines that I think could be informative. In addition, I would note that the altmetric scores for clinical practice guidelines can run from 1 to 576 in these orthopedic guidelines. Let's talk a little bit about how to identify relevant rehab guidelines. Dr. Proctor has shown the Guideline Central Rehabilitation page, which is a really important page to know about. Also, the ECRI Guidelines Trust website will provide guidelines of relevance to rehabilitation. One of the challenges that we've experienced in physical therapy is that many of the broader guidelines lack sufficient detail to guide clinical practice in, for example, physical therapy. So this has led to the development of discipline-specific clinical practice guidelines within each discipline. And so for that, I've shown here some sources in the APTA, the AOTA, and ASHA, who all have relevant guidelines for their disciplines, and their websites are here. In addition, particular academies or specialty organizations of the American Physical Therapy Association post their guidelines to their sites, so I've put them here as well. Those are some really good starting points for gathering relevant clinical practice guidelines that have good methods. But on to thinking about the methods. Beyond finding the relevant guidelines, how do you know which guidelines are of high quality? There are a couple of ways to do that. First, when the AHRQ had worked with the IOM to create standards, they also created a clearinghouse for guidelines in which the guidelines that were included were reviewed for quality. That was guidelines.gov. Unfortunately, 2 years ago, the funding for guidelines.gov was completed, and after a little period of uncertainty, the ECRI group took up that charge. And so ECRI Guidelines Trust is the current clinical practice guideline clearinghouse. But they also provide quality ratings of guidelines. So you can go to ECRI Guidelines Trust and see a quality rating based on the IOM standards. The American Physical Therapy Association also conducts quality ratings. They use the Agree To tool to judge the quality of clinical practice guidelines. And I've got the websites there. And I think finally, if needed, you could do an Agree To review of a CPG of interest to you. It doesn't take too long to train. You can just go to the Agree To website to train. And obviously you'd have a team of at least 2 people who would conduct that review. But that's a possibility for assessing what are high quality guidelines. So finally, when thinking about finding an area to focus on in implementation research. As Dr. Prue-Betker noted, we're going to want to have evidence-based practice on which to base this work. So we need to find strong recommendations, and those are usually identified with an A or a B rating, and they would be associated with stronger language, stronger obligatory language such as must or should. The recommendations should be clear and ideally easily converted into a performance measure. I did an informal review of CPGs in the physical therapy realm to see how common is it to have strong recommendations for evidence-based practices. And what I found among 21 CPGs that I looked at were 85 A-level recommendations, which would be must or should, and 114 B-level, which would also be must or shoulds. And so my takeaway from this is that we have a really strong foundation in existing clinical practice guidelines. I'm generalizing to rehabilitation now, but based on physical therapy, from which to look at whether there are practice gaps, whether there are quality improvement opportunities. And I think that our existing clinical practice guidelines provide a really strong starting point for implementation research initiatives. And with that, I'd like to thank my mentors, collaborators, and also the many people who provided me with statistics to help me support this presentation. Thanks very much.